Good afternoon, everyone. My name is Tara Johnson, and I'm with the Health Promotion and Disease Prevention team here at the Association of State and Territorial Health Officials. I would like to welcome you to today's interactive webinar, the Million Hearts webinar on implementing team-based care, a public health agency perspective, and implementing team-based care, a health systems perspective. ASTHO is hosting this webinar in collaboration with the American College of Preventive Medicine and with support from the CDC's Division for Heart Disease and Stroke Prevention. We are excited to host today's webinar, which will highlight different strategies that state health agencies are using to better integrate team-based care and also the strategies that the healthcare side is using to implement team-based care. The learning objectives for today's webinar are to understand the systematic review process of the Community Guide and the Community Preventive Services Task Force and how it informs evidence-based recommendations on cardiovascular disease. Also to learn how a state health agency is implementing team-based care throughout the state, and to learn how team-based care is implemented in the clinical settings by leadership in preventive medicine. We have an esteemed panel of experts that will be speaking with you today. Following my introductions, all the speakers will present their slides. If you have a question, you are welcome to post it in the chat box on your screen at any time during the webinar. These questions will be used during the Q&A section after today's presentations. At the conclusion of the webinar, you will be directed to an evaluation survey. Please take a few minutes to inform us about the work that you are doing. Before introducing our first speaker, I will hand it over to Mike Berry and Sharon Moffitt. Mike Berry is the Chief Staff Executive for the American College of Preventive Medicine, responsible for carrying out the college's mission to provide leadership in the science, policy, and practice of preventive medicine. Sharon Moffitt is the Chief of Health Promotion and Disease Prevention with the Association of State and Territorial Health Officials. Her work at the national level has included leadership roles as an executive officer on the National Forum Board for Heart Disease and Stroke, and as a liaison to the Community Preventive Services Desk. Mike, I'll hand it over to you.
Thank you, Tara. Good afternoon, everyone, and thank you for attending this very important webinar on implementing team-based care. As Tara said, I'm the Executive Director of the American College of Preventive Medicine, or ACPM, and ACPM is very pleased to be co-hosting this webinar. ACPM, for those of you who don't know us, represents physicians who are dedicated to prevention. Our members in the organization are committed and work really at the interface between public health and health care and take a very broad systems and population-based focus on the work that we do. So this particular webinar was very much aligned with what we're about, and we're very pleased to be working with ASTHO on this. I would like to personally welcome all of our members at ACPM that are on this call. And as I said, again, we are very pleased to be collaborating with ASTHO. We have worked together with ASTHO on a number of areas, including public health and primary care integration, which both of our organizations believe really is the future of where our healthcare system is heading. We've also worked closely with ASTHO on the Million Hearts initiative, which this webinar is tied around. A couple more words about the webinar and what you'll be hearing. Although team-based care is an evidence-based intervention, there are challenges and barriers to implementation for both state health agencies and healthcare providers and others within the healthcare system. We hope that our members and the other providers and public health practitioners on this call will be able to learn more about the value of team-based care and learn about some of the tools to overcome some of the challenges of implementation. So with that, let me stop and I'll hand it over to Sharon at ASTHO.
Good morning and afternoon, everyone. Thank you very much, and Mike, thank you. It's ongoing, very strong partnership and with ACPM and the Association of State and Territorial Health Officials who represent all the states and our territories. We have definitely building on a very, very strong and long relationship. And really, I think this discussion today and this webinar helps us really focus on what that role and that coordination is between the clinical care world and the public health world and how we can continue to work together. We're very excited to be hearing from the expertise on the webinar that you'll hear from today, and particularly around the recommendations of the task force in this area. Team-based care, as I think you will learn and see, is a critical bridge between the clinical setting and the community setting and supporting individuals. Obviously, we'll be very interested to hear from the actual teams that are in the field using this. What are the opportunities and barriers, how they're financing that work. I do want to kind of continue to reinforce and invite any of you, if you're not part of the ASTHO-supported Public Health and Primary Care Integration Collaborative, we'd be very excited to have anyone on the phone be part of that. Mike Berry and his team are very involved in helping that particular piece of work. I also want to bring to your attention, and we can talk about this at further detail if there's questions at the end, around ASTHO's current work with 10 states and many national partners on the Million Hearts Initiative to reduce hypertension, of which team-based care is one of the critical levers to achieve the NQF 18 standard around reduced hypertension. So more as we go forward. At this point, I'm going to turn it over to our presenters and Tara as we move forward. Thank you so much for being on this call.
Great. Thank you, Sharon and Mike, for offering your perspective. Our first speaker is Anil Thorda. Anil is a Senior Service Fellow in the Community Guide Branch at the Centers for Disease Control and Prevention. Anil was a lead researcher on the systematic review on the team-based care intervention. I will now turn it over to Anil.
Thank you, Tara. I am Anil Thorda. I am going to tell you today about the Community Guide Systematic Review on Team-Based Care for Blood Pressure Control that formed the basis for the Community Preventive Services Task Force. This is our standard disclaimer. The findings here are the views of the author, and the Community Preventive Services Task Force do not necessarily represent the official position of the CDC. So just as the agenda for today's presentation, I will start with an overview of what the guide is and the Community Preventive Services Task Force very briefly, and then we'll get into the details of team-based care, the conceptual approach, the results, and the findings, as well as the task force finding statement. Slide 6, the Community Guide is a product of an independent US-based task force called the Community Preventive Services Task Force. It's a non-federal, independent group of public health experts from all across the country that are appointed by the Director of CDC. The focus here is on population-based interventions, both in the community and in healthcare systems, and the Community Guide is a source of evidence-based conclusions and recommendations regarding use of various intervention strategies in the public health world. So slide 7, so some issues that are considered in Community Guide reviews while we do any of these reviews. Central to each review is an intervention, by which we mean a policy or a program or a service or a strategy that is aimed at improving population health, both in terms of health behavior and actual health outcomes that would reduce morbidity and mortality. We also look at additional benefits from the intervention, potential harms that could happen to populations from the intervention. We also have an economics team that does economics review for cost effectiveness and cost benefits out of information. We identify crucial evidence gaps. We look at considerations for implementing the intervention successfully. And very importantly, we are looking to see what conditions or what populations or what settings the results are applicable to, because decision makers and policy makers need to know about the applicability and generalizability of results for their specific constituents. So having said that, let's get into the team-based care details. Before we started the review, we put together this cardiovascular disease coordination team and the guide, which consists of experts from research, practice, and policy, both from CDC as well as our external partners. Our CDC partners were the Division for Heart Disease and Stroke Prevention. We also had task force members and task force liaisons on the team working together to improve the quality of the product. So before we get into the definition of team-based care that we adopted for blood pressure control, let's see what team-based care itself is. You're all probably familiar with the chronic care model from the 1990s, which has evolved more recently into the more sophisticated patient-centered medical home concept. The principles here are to focus on implementing practice teams to have better collaboration and care coordination, as well as better clinical decision support. And the other important principle is to involve patients actively in their own care to improve their self-management skills, to improve their knowledge. And these days, these are often supplemented by system support, such as computer systems for decisions, for information, as well as surveillance. On slide 10 is a definition that the team put together applying the team-based care concept to improve blood pressure outcomes. And team-based care was defined as a health systems level organizational intervention that incorporates a multidisciplinary team to improve the quality of hypertension care for patients. Team-based care is established by adding new staff or changing the roles of existing staff to work with a primary care provider. Each team includes the patient's primary care provider, and other professionals such as nurses, pharmacists, dietitians, social workers, and community health workers. Team members provide process support and share responsibilities of hypertension care to complement the activities of the primary care provider. These responsibilities chiefly include medication management, patient follow-up, and adherence and self-management support. And it continues on the next slide, but the highlights are that the focus is on better care coordination, better concordance with evidence-based guidelines for providers, to establish sort of structured follow-up mechanisms for patients, and to promote the sort of active skills and knowledge from patients so that they're engaged in their own care to improve health outcomes for blood pressure. So slide 12 is the analytic framework or the conceptual approach that the team saw as team-based care working in improving blood pressure outcomes. So team-based care organizes health system staff that includes physicians and nurses and pharmacists, social workers, dietitians, and other professionals, and results in the better organization of teams, which includes the patient as a central component. This would improve team member collaboration in terms of care coordination and communication and decision and process support, leading to better support for patients with high blood pressure or hypertension in terms of better medication management, support for adherence to medication and other lifestyle changes, as well as support for self-management. All of this would lead to improved quality of hypertension care, reflected in terms of concordance with evidence-based guidelines, better patient participation, and better care experience for patients in the health system, leading to improved satisfaction with care for patients, improved adherence to treatments, ultimately leading to better blood pressure outcomes, both in the proportion of patients who have their blood pressure controlled, as well as absolute reductions in systolic and diastolic blood pressure, ultimately leading to reduced CVD morbidity and mortality. And we also thought that if the team-based care works for hypertension, it's likely to work for commonly occurring comorbidities such as diabetes and high cholesterol. So these were the research questions. The main research question, of course, is to see how effective team-based care was in improving blood pressure outcomes. And like I said before, we also wanted to look at outcomes for comorbidities. And in addition to that, we also wanted to see what are the other variables that would affect the effectiveness of team-based care by the various population characteristics such as age or gender or race, ethnicity, or the size of the organization, the setting in which team-based care was carried out, the types of team members in teams, what are the interaction and the components of the team-based care intervention itself. So the next step in the systematic review was to do the literature search once the conceptual work was done. So we did it in two steps. The first step was to identify existing systematic reviews of team-based care itself. And we did identify one by Walsh 2006 where the methods were very similar to a typical community guide review. And they had identified 28 studies of team-based care for blood pressure control. So we adopted Walsh and updated the search from 2003 to 2012. And we identified a further 52 studies from 70 published papers of team-based care. So in total, we had 80 studies of team-based care focused on improving blood pressure outcomes from 1980 to 2012. On the next slide, this is the interval body of evidence, the studies that we identified from the updated search from 2003 to 2012. This is the typical body of evidence table that we use for all of our guide reviews. This shows the quality scoring that we conduct for each of the studies, a very rigorous process done independently by two people, where we classify studies by the suitability of study design into greatest, moderate, and least, and also by the quality of execution, how well the studies were carried out into good, fair, and limited based on the number of limitations that are assigned to a given study. So this is just the distribution of the studies by those two metrics of quality scoring. So then going into the results for the of the update interval studies, the 52 studies that we found from the Bridge search. Most of the studies were in the U.S. healthcare system, and as you would expect, adults and older adults were well represented, as well as there was balance across gender in the study populations. The majority of the teams added one team member to work with the primary care provider and the patient. In most cases, this was either a nurse, either an RN or a nurse practitioner, and or a pharmacist that was added to work on teams. And the other thing that we noticed was there were three main types of team-based care models that people were using. One was where the added team member could make independent changes to antihypertensives. Second, where they could suggest changes and the PCP would approve the actual changes. And the third was where they didn't make any suggestions or changes to medication, but they only provided support to patients in terms of information as well as medication adherence support. So on slide 17, this is just one of the graphs that we did for one of the outcomes. This is the proportion of blood pressure controlled. That was 140 by 90 for people without diabetes, and 130 by 80 for people with diabetes. So you can see the zero line. Anything to the right of the zero line is in the favorable direction. So this is comparing the proportion of patients who achieved blood pressure control while receiving team-based care compared to usual care. And as you can see, we had 33 studies that reported this outcome. The median of improvement was a very strong 12 percentage point improvement in those patients who now had their blood pressure controlled after they received team-based care compared to usual care, with the IQI ranging from 3.2 percentage points to 20.8 percentage points. So we did similar graphs for systolic and diastolic blood pressure. I'm not showing that to you in the interest of time. Then when we looked at the Walsh review, the original review from which we updated from 1980 to 2003, the literature search was, and compared it to the community guide search, we found the same sort of trends. There were robust improvements in all three blood pressure outcomes when people received team-based care compared to whatever type of usual care that they were receiving. And when we looked a little deeper into the data, as I said before, most of the studies had either a pharmacist or a nurse. Both of those models were equally effective in improving blood pressure outcomes. We did see, though, there was a larger proportion of patients with the blood pressure controlled when pharmacists were used on teams. That was just a finding we saw. Very limited studies were available for other professionals, such as social workers or community health workers being used in these team-based care models, so that was identified as an evidence gap. When we looked at the type of roles related to medication management, the first two types of models where changes could be made independently by, say, a pharmacist on teams, or the recommendations to changes could be made to PCPs, those showed larger effect estimates for blood pressure outcomes compared to when only knowledge and adherence support was provided by team members to patients. The task force also makes it a point to consider important aspects of implementation that will be useful to the field. So this is the list of those that we identified from our review, as well as another piece that came out by Carter and colleagues in 2012. From the provider-related perspective, reimbursement decisions for all the providers in the team, audit and feedback mechanisms, just the constitution of the team and the dynamic of the team, what would be the type of team members that would be added, the number of team members, the roles that they would adopt, the training that people need to be on teams, what is the business model for this sort of system and organizational change, how could you expand team-based care for multiple CV risk factors, what are the system support that you need to put into place in today's world with technological advances like EHRs and CDSS, in terms of decision support or information support or just identification of patients who have uncontrolled blood pressure. And also resources for patients, both for education as well as self-management support, both in the healthcare system and in the community, and sort of stakeholder engagement that is sort of relevant to all of these factors. These were the aspects of implementation that were identified. And so in summary, team-based care to improve blood pressure control incorporates a multidisciplinary team. The team includes the patient at the center of the team, along with their primary care providers and other professionals such as nurses and pharmacists. It's found to greatly improve blood pressure outcomes. It requires health system level organizational change, of course, to be successfully implemented. It's applicable to a variety of U.S. populations and settings. It could potentially serve as a key component of the patient-centered medical home model moving forward. It can also, this approach can be used to address multiple severe risk factors and possibly other risk factors as well. And we also did an independent economic review. I didn't show you the detailed results here, but the economic evidence suggests that team-based care for blood pressure control is cost-effective. So based on that evidence, this is the official statement from the Community Preventive Services Task Force for team-based care. And it reads, the Community Preventive Services Task Force recommends team-based care to improve blood pressure control on the basis of strong evidence of effectiveness in improving the proportion of patients with controlled blood pressure and in reducing systolic and diastolic blood pressure. Evidence is considered strong based on findings from 80 studies, so that's the Walsh review as well as our review, of team-based care organized primarily with nurses and pharmacists working in collaboration with primary care providers, patients, and other professionals. The economic evidence indicates that team-based care is cost-effective. And if you click on that link at the bottom, you will go to our website with these results as well as the list of studies that were in, as well as evidence tables and other resources related to the review. We also identified evidence gaps. Most of the times we didn't see large-scale real-world studies. More information on population characteristics and socioeconomic status would always be helpful. Just in terms of the intervention, what are the sorts of communication, interaction that was going on between providers? What is the use of technology in improving team-based care? We didn't really see much of that. And also reporting more on morbidity and mortality outcomes from team-based care would be helpful for future research. So please visit our website. We have over 200 recommendations from the task force across a range of public health topics. And if you do have any questions, please don't hesitate to contact me at any point. Thank you.
Great. Thank you, Anil, for your presentation. The next presenters are Ms. Carrie Meek and Dr. William Doucette. Ms. Carrie Meek is the Health Systems Coordinator with the Iowa Department of Public Health. Previously, she was the Heart Disease and Stroke Prevention Program Manager. And we also have Dr. Bill Doucette, and he is the Professor of Health Services Research at the University of Iowa College of Pharmacy. I'll hand it over to you two.
Thank you. Terry, you start out. Terry?
Hi, good morning. This is Terry, and I would like to thank you for letting us participate. We're going to talk a little bit about some of the actual implementation of this intervention that we've been doing here in Iowa. And with me is Bill Doucette, who is actually heading up the actual work. And I think that we've already talked a little bit about the national background for using this intervention with the previous presentation from the community guide. And actually here in Iowa, the University of Iowa College of Pharmacy has a history of conducting research into provider-pharmacist teams, and Dr. Barry Carter there has led research trials which assisted in the intervention becoming evidence-based, as talked about in the previous presentation. The majority of the research, however, had been conducted in clinics or hospital outpatient clinics where the pharmacist was part of the clinic, and primarily in urban areas here in Iowa. And so our idea under the Heart Disease and Stroke Prevention Program initiated a contract in 2012 to 2013 with the University of Iowa College of Pharmacy to conduct non-research interventions with clinics in micropolitan and rural areas where the pharmacist was not actually part of the clinic but would be in a separate site. The University of Iowa College of Pharmacy was also instrumental in the development of many of the Million Hearts Team-Up Pressure Down tools and resources that can be found on the Million Hearts website, and which we'll probably talk about a little bit further as we go along.
The University of Iowa College of Pharmacy team was led by Bill Doucette, who's going to speak in a few minutes. They created a curriculum for use with the participating physician-pharmacist teams that we worked with, and a resource notebook for each team member. 11 teams were recruited across the state, and Bill's team trained them, monitored their progress, and offered technical assistance, and then followed up on outcomes from those teams. And now I will turn it over to Bill, and he'll talk a little bit further about what his team did with the actual sites.
Thank you, Terry. Hello, everyone. So the objectives of our project were really to develop teams, and we viewed this primarily as team building activities. We were able to recruit providers, primary care providers, and then community pharmacist teams in the same community to manage hypertension. Then we assessed the impact of the team approach on practitioner-reported consequences, and then examined obstacles and ways that they overcame the obstacles. So as Terry mentioned, the overview, we really focused on rural and micropolitan communities in Iowa. You know, that's where scarce resources are. However, a lot of these communities do have a primary care provider and a community pharmacist, so we thought that would be useful. We used incentives to attract the team members. Then once we had recruited teams, we conducted face-to-face team building sessions. Each team managed blood pressure for about 3 to 5 months, and that varies because of the time it took to recruit the teams. And then evaluation, we collected and analyzed data using a multi-case approach. So we looked at each team, the extent that they had developed the team approach, and then what effects that had or what consequences that had. So just a little bit more detail about what we actually did. The team recruitment, we contacted pharmacies and physicians using letters and emails. We used some sites that are associated with the College of Pharmacy that provide experiential learning opportunities for pharmacy students. We also worked with Iowa Research Network, which is a network of physicians throughout the state. So once we had one team member interested, they recommended another team member. You know, a pharmacist might recommend a physician, for example. Then we had to contact that next member, so that's one reason why it took a bit of time just to recruit the teams. We did have a few teams that the members, the practitioners, were actually in the same clinic building. However, in no case were they under the same ownership. For example, the clinic had space and they were renting space to a community pharmacy that was actually in the clinic building, but it was a separate business entity.
Bill, I don't know if you can see the notes, but quite a few people have called in wanting to know a little bit more about the incentives, so you might be able to talk about that a little bit.
All right, sure. The incentive, just to keep it simple and not have any fee-for-service, you know, if they're trying to provide care, we thought that the services more generally would be covered under the usual ways that patients pay for care, probably insurance for the most part. But we did offer them $1,000 to participate in the whole project, and so that was per site. So the pharmacy got $1,000 and the clinic got $1,000, and that would cover their time for participating in the team building. Also, you know, coordination, any changes they need to make, and then also, as I'll mention later, they participated in some surveys, so online surveys.
And that funding did come from our heart disease and stroke prevention grant that we had.
Thank you, Terry. Okay, so the team building, once the teams were recruited, we had a face-to-face team building session that lasted about an hour, and some of these were held in the clinics and some were held in the pharmacies, depending on who had better space available. Most of the time they were like a lunch meeting, a few were in the evening. So during these meetings, we really wanted to get them to talk about, well, how would you see this team approach working given this situation, given your team's situation. So we talked about the roles for the practitioners. You know, for example, obviously the PCPs were responsible for overseeing the hypertensive care. In many cases, the pharmacists were doing blood pressure visits where they would do a check and then talk about medication adherence. In some cases, making recommendations to the physician, contacting the physician to change medication. They developed communication procedures. You know, would they use faxes? Would they use email, telephone? What was the best approach? They talked about how would they identify patients. They discussed one case just to get a feel for what the thinking was for the treatments. So during the call or during the meeting, we wrote down the issues and decisions that they made, and then we printed that out and gave it back to them. So they had that. We didn't print it on site, but we printed it and sent it to them the next day through email. Also during the meeting, we provided them with a toolkit, which really was a kind of a broad tool. It had JNC 7 guidelines. It has some evidence about the team-based approach using pharmacists and physicians. Barry Carter and his team had developed a very similar toolkit and we modified that. They were using theirs within a clinic setting. We also included in there some patient education sheets that we had gotten from a variety of sources. NHLBI, American Heart Association. I can't recall exactly all the sources, but that was given to both the providers and the pharmacists. So then after the team building, they provided the team care for, like I said, 3 to 5 months. Then we had an evaluation. So we really were trying to focus on, did they establish a team approach? So we looked at also the consequences and obstacles. So we used kind of 2 main data sources. One was online surveys of practitioners. So the providers and the pharmacists both filled out online surveys, and that was a baseline, and then post the team care period. And these surveys were semi-structured, so they had some close-ended questions with a scale, and then some were more open-ended. They asked about the team relations, how they developed the team, any obstacles, ways they overcame the obstacles, suggested improvements, and whether they would continue doing the team approach. We also had the pharmacists keep blood pressure visit logs, and they also did some visit notes of their own in their own documentation system. We asked for redacted versions of those. Once we had the data, we wrote a case report for each team, so kind of a within case report, and then we compared across the cases for the analysis. So the results, we had 11 teams, provider pharmacist teams. In some of these teams, the providers were physicians. In some cases, they were nurse practitioners, and we did have at least one physician assistant. I think we might have had 2. So that it was across the gamut for that. We divided the cases into 3 types of teams. One we called worked well, and in this case they developed an effective team approach or a system that would support them communicating and roles that they had that would fit within a team approach. And they actually did a fair number of blood pressure visits and worked with a reasonable number of patients. They had fewer obstacles reported. Then that was 4 teams, and then we had 5 teams that had limited success. They had some teamwork, 3 to 12 blood pressure visits. Patient recruitment was an issue, so some of them looked like they had developed a workable team system, but they just didn't see very many patients. And so patient recruitment was mentioned. You know, patients didn't think they needed the team approach. Workload was also an issue. I know in one case, both the pharmacist and the physician had substantial administrative duties, and so they weren't able to provide the clinical care as much as they wanted to. And then in 2 teams, we didn't get the team work established. And so that was all the cases there. So just thinking about what did we learn from this, I think this limited team building approach, which really, you know, we did 1 session and then encouraged them to do a follow-up, and we did some follow-up emails, but we didn't do a lot of additional calls or communications as a team. We're able to get some teams established. We didn't have good data on blood pressure readings. That it wasn't designed to do that at this point. But I think we did see that there was closer monitoring of blood pressure. There were definitely more blood pressure readings taken for the patients. Some medication changes were made. It looked like some teams, that was an accepted role that the pharmacists and were ready to assume, and the providers were willing to give to them. And in other teams, that wasn't as common. It was just more kind of doing blood pressure checks and talking to the patient, not advising on therapy changes. Team relations improved, and that was based on a validated scale that we had on pharmacist-physician collaborations. Obstacles were pretty broad. Some cases, the team vision just didn't seem to get established with the 1 visit or 1 team meeting. I think the workflow, you know, establishing new activities cropped up for some sites as well. Patient acceptance was found. It was inconsistent. Sometimes it wasn't great, and sometimes it was better. In talking to one pair, they reported, the pharmacist reported, whenever the provider referred them, then the patient was very more positive and interested in it. And reimbursement is a long-term issue that was recognized by the teams. But again, we paid them kind of a chunk of funds to participate and do this. It wasn't a fee-for-service approach. So in conclusion, I think more support is needed to better establish this team approach where the teams aren't in the same building. I think this community-based approach has some good potential. So some of the thoughts we had were to follow up on the joint sessions. You know, have them do a conference call, you know, after a few months, or at least periodically. Excuse me. I think to address the workflow issues, we could provide tools or advice on practice change. You know, I know in some community pharmacies that are doing medication management visits that take longer, they actually have moved to using an appointment system where patients make appointments with the pharmacist, and that's a fairly new change. I think a broader discussion with the patients might be useful. We didn't do any activities in the communities directed, you know, announcing this team approach. That's something that could be considered. And I think one of the things we hope to do is work with the payers or health systems themselves about trying to support this financially. Is there a way that we could pay for the blood pressure visits? I think that would be a positive thing. Year 2, we're going to do some more work with some of the established teams, and then build new teams as well. And we're starting to develop some some materials and some thinking about how well could this team approach work for patients with diabetes. So thank you. We'll have questions later, is correct?
Yes, that's correct. Thank you for your presentation. We will have, I've seen quite a few questions come in on the chat box, and we will definitely address those at the end during the Q&A session. If we do not get to all of the questions, we will make sure that contact information is given so that everyone will have a follow-up to those questions. And on the screen is Ms. Meek and Dr. Doucette's contact information. The final presenter that we have is Dr. Randall Stafford, and he is a professor of medicine and the director of the Program of Prevention Outcomes and Practices at the Stanford Prevention Research Center. I'll hand it over to you, Dr. Stafford.
Thank you so much. It's great to be with all of you, and thank you for joining us for this session. So my role is to talk about some of the practical issues and how we can move towards more effective prevention in primary care. Here is a list of the topics that I'm going to cover, and want everybody to recognize the enormous potential that exists for improving clinical and community prevention services. And team-based care is clearly a central strategy, but multiple opportunities exist for integration of primary care and public health. And I'm particularly excited by the practical challenges that are presented by the Million Hearts Initiative. So a couple of things that I want to talk about are, first of all, the enormous barriers that exist to providing good primary care prevention. And these may have a lot to do with our current system of care. We work in a healthcare system that tends to be oriented towards a acute care approach to problems. I'm sorry, I'm having some trouble advancing the screen here. Here we go. And it's a system where prevention isn't adequately reimbursed, and where we have a physician-centric delivery system where the emphasis is really on episodic visits rather than continuity or longitudinality. It's a system where we have difficulty valuing future benefits of prevention, and where there is many logistical barriers, particularly in the primary care setting, and limited ability, at least at present, to integrate with some of the larger goals of a public health system. So one way of approaching sort of the multiple issues we have is a social ecological model, and I'm sure this is familiar to many of you. But the real point is that individuals are more than simply individuals, and that they are part of various institutions and organizations that serve their needs. And these can include things like work or family or the healthcare system that's built around them. But all of those institutions work within a community setting, and that community setting is, of course, surrounded by a societal setting. One of my points here is that we can talk about team-based care in a very limited way in terms of a provider and a person who is involved in helping that provider, and talk about the patient as part of that team. But in some sense, we have a very large team, and I want to make the point that there's a lot of things we can do to improve care when we start thinking about the full context of the determinants of individuals' health. So in terms of an example of prevention services where improvement is needed, I want to focus on aspirin. Aspirin is one of the goals of the Million Hearts Initiative. It's the A in the ABCS for aspirin, blood pressure, cholesterol, and smoking cessation. It's known that for primary prevention and secondary prevention, aspirin has substantial benefits. There is perhaps stronger evidence in secondary prevention, where we're providing aspirin to those with known heart disease or a past stroke, but evolving basis for primary prevention for cardiovascular disease, and some exciting new information about aspirin and cancer prevention, particularly in the area of colon cancer. Aspirin may be a little different from some other preventive services in that we really need to focus not only on the benefits but the risks involved. And this diagram illustrates sort of our goals, which are to not only make sure that those people who have expected benefits that exceed their risk are taking aspirin, but trying to avoid the flip side of people using aspirin when the risks are greater than the benefit, where they really don't have a substantial chance of benefiting from aspirin. They shouldn't be taking aspirin. We know from data that my colleagues and I have collected that aspirin use for primary prevention, while it's grown substantially in the last decade and a half, still seems to be insufficient. And if one looks at the various predictors of aspirin use, one can see that for some target populations, those of older age, those with chronic disease conditions, we're getting use rates in the range of 50 to 60%. But if we look at the context in which people make the decision to continue to take aspirin, we see that there's a high correlation with having discussed aspirin with their physician and with the amount of knowledge they have about aspirin. And so this suggests that there's a lot of room for improvement, and that this primary prevention strategy could be really modified and improved by better coordination of the primary care process with the overarching public health goals. One of the particular challenges of prevention is to make sure that prevention is valued, including how it's reimbursed in a primary care setting. And better reimbursement for prevention provides not only an incentive for providing the prevention services, but it may remove some of the incentives for neglecting prevention. And furthermore, it reinforces the value of prevention. Even if the reimbursement may not adequately reimburse physicians for their time and effort, the fact that prevention is increasingly being reimbursed signifies that it's a valuable service for physicians to be taking on. But there is a number of critical areas where even if we have prevention being reimbursed, the ability of providers and patients to take on this decision-making process depends on other factors, including some of the factors that Bill had talked about in his presentation. One of the particularly important parts of prevention has been the Centers for Medicare and Medicaid Services taking on the issue of trying to determine what services should be reimbursed. And this is directly related to the U.S. Preventive Services Task Force recommendations, and the ability of Medicare to take on this reimbursement issue has been the basis of the Affordable Care Act beginning to reimburse for prevention services as well. And I just want to make the point here that this idea of providing reimbursement for prevention is relatively new, and in my mind surprising that we haven't made more progress in this area up until the last 5 years. When we start talking about better prevention, we're often talking about behavior change. And behavior change not only at the level of the patient or the consumer, but quite often at the level of health systems and healthcare providers. And I want to make the point that as we think about how we can facilitate better prevention, we need to get out of the model of thinking that this is all about information and education. We know from multiple studies that information alone does not change behavior. Instead, we need to think about compelling and actionable messages. We have to have the goal of activating and having an informed consumer as part of this process. What I'd like to show you are just a couple examples that I'm working on in concert with the Partnership for Prevention to think about how to get out the message about aspirin use. So what you see here is the top portion of a fact sheet. This is a draft version. But the whole idea here is to provide some compelling messages to consumers that both motivate them to take up the issue of aspirin with their physicians and motivates them to have that discussion with their physicians where they make a decision about aspirin use, but also informs them and makes them an activated participant in their own care. Similarly, the next slide shows a website also under development that has the same goal. And I think increasingly we need to connect the primary care process with the overarching public health goals. I want to go back to the whole issue of team-based care and talk about it being one of a number of strategies that really can help translate prevention goals into primary care. And there are a number of practical issues, including things like matching the complexity of particular tasks with the costs of providing case managers. What that often means is thinking very hard about exactly what is the training or the level of education needed for a person who's helping with team-based care. We also need to think about some of the issues that Bill mentioned in terms of adequate training and quality control and ensuring team cohesion. I want to just give you a couple of insights from two studies that I've conducted. One of these is included within the review that Anil discussed. It's reference 30 of the new 52 studies that are included in the review, and the reference is from my colleague June Ma, who is the first author. So we looked at using nurses and dietitians to reduce cardiovascular risk, not only for blood pressure, but for the whole range of risk factors. We used case managers and tested the effectiveness of these case managers against usual primary care in a county health system. And what we found was successful reduction in risk for the intervention versus control, with a particularly prominent effect on systolic blood pressure, but with effects on other risk factors as well. The second example is using health educators and community health workers in the management of obesity. And this too was in a county setting. We focused on changing the weight of obese Latino patients using a health center, followed them for 24 months. In this model, we used two different forms of intervention. One was a health educator alone, providing both group and individual sessions, and then also adding to that a community health worker and testing these two different interventions against usual primary care. Our results in this trial were not as successful, but we did find that there was a 6-month reduction in weight for the combined health educator and community health worker intervention. But unfortunately, this did not persist. And in my mind, did not persist because of the obesogenic environment that many of our participants were living in. So the next slide simply looks at the whole range of different case management roles that could be that I have had contact with. Obviously, pharmacists should be added as an additional type of case manager, particularly when we're talking about blood pressure and other conditions where medication management is critical. I want to make the point that this list includes some people who are highly trained and can take on very complex tasks that approach the sort of work that physicians often do. On the other hand, we also need to think about those people who are at the front line, who are making appointments for patients, who are out in the community. And in many cases, that type of person may be very effective provided that we provide the training that they need to help with the process of team-based care. So I want to make the point that we shouldn't limit our teams to thinking about just health professionals, and that our team includes not only the primary care provider, it includes case managers, it also includes the patient, and in some sense includes the community and our societal norms and rules that we have around things like reimbursement. So just to finish off, I wanted to again stress the need for integration of services across the different provider types, across the different clinical conditions, and across the different levels of determinants of health. And we also need to think about integrating our efforts to improve prevention, from patients to providers to system-wide changes across different types of government agencies and jurisdictions, and particularly trying to integrate the healthcare process in primary care with public health goals. So I think we can move towards discussing in our last remaining minutes here some of the implications.
Yes, thank you. Thank you very much for that presentation, Dr. Stafford. It looks like we have just about another couple of minutes for the Q&A section. I do apologize. We will not be able to get to all of the questions that were asked, but we are writing those down on our end to make sure that we can get back to you all individually. And just because of the amount of time, I'll pull up our last slide so that you can jot down my contact information and also Andrea Lowe from ACPM's contact information in case you have specific questions for us, but also if you have questions for the speakers and need their contact information. But I think we'll have time for one question, and we'll go in order. So there was one question about the Community Guide Task Force, that they recognize the limitations of their recommendation and the need for additional evidence. So Anil, does the task force have plans to conduct further analysis?
I mean, the limitations there are from the evidence. So if these are the gaps that are identified in the evidence, so if that information is available in the published papers, then the task force would include it in their analysis. And also the task force updates their reviews every 5 years. That's the congressional mandate that they have. So they're calling for more studies to report those gaps, on those gaps, so that the synthesis could be that much more useful.
Fantastic. Thank you, Anil. There were quite a few questions about the specific processes and activities from the second presentation that there was. I do want to let everyone know that ASTHO is actually pulling together a case study on Iowa's experience with Million Hearts. So hopefully that will be able to answer some of your questions. And we can also, again, get you in touch with the speakers if you have more specific questions for them. And with that, we will look to conclude the webinar. I will just want to let you know that a recording of today's webinar will be available on our website within the next few days on the web pages that are listed here on your screen. Please check our newsletters and website for more information regarding future webinars as additional cardiovascular disease resources. If you'd like to subscribe to ASTHO's Primary Care and Prevention Network newsletter, or if you have any follow-up questions at all, please contact me, Tara Johnson, at tjohnson@astho.org. We hope that all of the listeners will use this webinar as a resource and will share the link with others once it is available. Thank you all, and enjoy the rest of your day.
Thank you.